I am really excited to introduce Dr. Chase Anderson. Um, Dr. Chase T.M. Anderson, but just call him Chase, is currently a child and adolescent psychiatry fellow at the University of California at San Francisco and graduated from adult psychiatry residency at the Massachusetts General Hospital and McLean Hospital. He completed his undergraduate education in chemistry at the Massachusetts Institute of Technology and his master's in biological engineering at MIT as well. He's a graduate of the Northwestern Feinberg School of Medicine. His writing has appeared in WBUR, NPR, Scientific American, Stat News, the New England Journal of Medicine, and other news and journal outlets. In his free time, he enjoys going for long walks, listening to K-pop, reading fantasy books, playing soccer, writing, and planning dinner with friends. Welcome, Chase.
Hi, everybody. Thank you so much for having me. It's really awesome to be here. And yeah, feel free to call me Chase. I'm trying to flatten the hierarchy as much as possible. So, like, I don't do that doctor stuff. It's like a mess. I also want to take a moment just before we get started. There's been a lot of like racial violence in America. So, I always want to like take a pause and just like say that like we're all here together, and that I know this is a really hard time for everybody. So whatever you need to do during the lecture, like if you need to take a break, if you need to go somewhere, if you're like lying on your couch, like I'm sitting on my couch with like a blanket on, so like do what you need to do. Like I'm just not showing it to you right now. So do whatever you need to do. I'm also here for any questions that come up during this. I just want you guys to know this is like an open space, to ask all the questions that you've like always wanted to ask too. All right, let's get started. Uh, uh, uh. Okay, can you see that?
Yep, we
Okay,
can.
cool, awesome. All right. So, what we'll be talking about today is identity and leveraging social media. So, we'll be talking about how identity impacts mental health and how we can use technology to find our voices. A lot of this will be Q&A, and so you guys can feel free to ask anything about my own journey, as well as what I've seen with other people, as well as how social media, as well as just professional identity on social media is very much a thing right now that we can use to help other people. So this talk was actually given by myself and a colleague, Mark Fusunyan, when we actually were residents at MGH. He's still there and then is escaping out to Stanford later on. And then I am at UCSF currently. So we did this talk in our second year, and it actually became like my calling card in some way. So sometimes those talks actually do last for longer than you think they will. All right, an overview of what we're going to talk about today. Part one is what is identity? We're going to go through some definitions and just like bring everybody up to speed, because one of the big things that we noted when we first started doing this talk was that a lot of people might have different definitions for different things. So we kind of want to standardize some of that. Part two will be how is identity related to minority stress? So just we're going to talk about what minority stress is, how it affects people, and how it plays out in different parts of America. Part three will be minority stress in America and in healthcare. So what's the fallout in terms of mental health for different populations who experience minority stress? Part four is how do we help and how do we grow? Because I always like to end on a high note, as well as to give people some tips and tricks that have been like proven. Because one of the things we see is that we keep trying to reinvent the wheel when a lot of people have done a lot of the legwork already. So let's use that and then move forward. And then part five will be rising from the ashes. So when I created my pseudonym back in the day, so about 2 years ago, we're going to go through that and how I utilize social media to actually find my voice again, because at the time I was pretty depressed and actually didn't know if I was right for medicine in a lot of ways. And creating this account and being on Twitter would actually help me realize that I was not by myself in a lot of ways. And then part six will be the Q&A. So, first, what is identity? So, the typical definition is the fact of being who or what a person or thing is. So, I sit in front of all of you and I'm African American and gay. Those are things that people would peg me as. However, more than that, identity is the way you think about yourself, the way the world views you, and characteristics that define you. So, although I'm African American and gay, a lot of my friends from MIT actually call me a rainbow or unicorn phoenix. The reason that came about is because they said I was always rising from the ashes of discrimination and trying to spread magic throughout the world. So I identify with that nickname a lot more, and that identity in a lot of ways. So I take on certain labels that apply to me, and I also reject other labels that people try to throw onto me at certain times. So identity can be shaped by your culture and societal labels. So again, going back to I sit in the African American culture in a lot of ways. I also sit inside of the psychiatry culture. I also sit inside of people who live with mental illness because I live with depression and it's in remission, but I still am part of that culture in a lot of different ways. Identity can help us with decision making and community building. So just thinking about like how in Chicago they have Boys Town, and that's where like a lot of LGBTQ plus people go. And so thinking about how community is actually like physically there, as well as how community can be like in various forms throughout America as well as the world. Identity is a good thing, but can identity also be a bad thing? The short answer is yes. The long answer is the drive to protect our identity can sometimes prevent us from being open minded and compassionate, and it can be polarizing. I used to give specific examples for this, but now I just say, like, look at America and how polarized we are around identity. Identity can also impact our mental health if we don't identify as being someone with good qualities. Example, if we identify as lazy, we are more inclined to act lazy. So they did a study back in the day and they told African Americans that they would score the same as their white colleagues, and they did at the time. If they were told that they would not do as well, they actually noted that they were scored to be, they would usually score about 10 points lower than their white colleagues. So even the words that we use and the way that we present things to people can change how they internalize those facts, as well as how they think about themselves and their intelligence and their mental health. Identity can also impact our mental health if others aren't open minded and compassionate about how we identify ourselves. So, just thinking about since the 2016 election, we'll talk more about this in a little bit, but just thinking about how since the election, and especially recently, we've seen a rise in racial tensions as well as racial distress, as well as discrimination. An example of this is that we are seeing that Asian Americans are suffering from about, I think, sevenfold increase in depression and anxiety, and that's because of bigotry that they're facing because of coronavirus and how people are acting around that. So just thinking about how our mental health is affected when other people are not as open-minded and they're not thoughtful about who we are. How is identity related to minority stress? So we need to define what minority stress is first. The typical definition is the process through which stigma directed towards sexual minorities influences health outcomes. When this definition first came into being, it was around 2003, and it was by somebody who was looking at LGBTQ plus population specifically. And they noted that this group of individuals actually experienced certain stressors that then would lead to poor mental health outcomes. As time has gone on, a lot of other groups have actually adopted this minority stress model and seen that it actually applies to them as well. So this includes the Hispanic community, the African American community, the Asian American community. So the definition actually became broader, and out of that came minority stress theory. It's known as the more elegant explanation. So, individuals from oppressed social groups experience excess stress and negative life events because of their non dominant status or statuses, which can lead to or exacerbate mental health outcomes. These effects are unique, socioculturally based, and long lasting, which means they're additive. The way that I like to describe this to people is think about getting a paper cut. If you get one paper cut like once a day, then it heals, and then you're like, oh, I don't even remember that I got a paper cut. Imagine getting 1,000 paper cuts a day and you don't know where those paper cuts are coming from or how they're going to impact you. And eventually you're like dealing with a lot of wounds that you don't even know how to actually heal them anymore. And you're bleeding all over the place. Another way I like to think about it is I watch a lot of Sailor Moon, the original Japanese version. I actually have it on my bookshelf back there. You can't see it because there's like a lot of stuff on there. But in Sailor Moon, she actually has this thing called the silver crystal, and it helps embody like her power and her identity and who she is. And so imagine getting cracks in that shine. So you get one crack and then it heals. But if you get multiple cracks throughout the day, then you don't know how to put the shards of yourself back together. So I actually like that imagery a little bit more. Along with this comes institutional discrimination, so disparities that systematically favor certain groups. This can include housing, so thinking about redlining, where African Americans were only allowed to live in certain areas. And this is still playing out in America in many ways when you think about how people are approved for loans or not approved. And there's a lot of racial things that happen behind that. Along with this comes institutional discrimination in terms of schooling. So back in the day, in the 90s even, there was actually this thing called the busing system that they had in Boston. And so they were busing kids who were of lower socioeconomic status and were African American to white neighborhoods in order to go to schools that were better. People protested this at the time, and this was only in the 90s, so not even that long ago. And then said that like they didn't want them in their schools. So thinking about how that still plays out too. This also plays out in employment, health, and justice. How does minority stress play out in America and in healthcare? So a couple of statistics first. We're going to go into the racial ones at the beginning. A study by Randy T. Lee looked at major lifetime discrimination. So this included being abused, this included verbal abuse, this included physical abuse, this included being threatened. This also included things that were more subversive as well. 48.9% of African Americans said that they'd experienced major lifetime discrimination versus only 30.9% of white people said the same thing. They think that part of the reason it's so high is also because women are included in that as well. So white women do experience a lot of stress as well. In terms of day-to-day discrimination, so they looked at day-to-day events. So 44.4% of white people said that they had not experienced day-to-day discrimination. Only 8.8% of African Americans were able to say the same thing. So that's a pretty glaring, drastic difference. In terms of pay discrepancies, they also looked at people who came in at the same educational level and the same amount of degrees, and also then looked at how they were promoted or not promoted, as well as how they were paid. 57% of African Americans versus 32% of Hispanic Americans versus 31% of Native Americans versus 25% of Asian Americans said that they had experienced pay discrepancies because of their race, and 13% of Caucasians said the same thing. So this slide is a little bit busy, but I just want to draw your attention to the right column where it says yes regularly. So this is experiencing discrimination on a regular basis. 3.82% of white people said that they experience discrimination regularly or on a day-to-day basis. That's compared to 11.23% of Black people, 10.85% of Asian Americans, and then 8.16% of Hispanic Americans. If you actually look down the column, every race experiences discrimination regularly more than white people do. How does this play out for LGBTQ plus Americans? So they actually looked at different high schools and then gathered statistics about them as in LGBTQ plus populations. And all youths who were sexual minorities reported higher rates of violence victimization. This included feeling unsafe, being forced to have sexual intercourse, being threatened with a weapon, being bullied at school or online. An example of this is that 27.7% of gay males said that they were bullied at school compared to 14.6% of heterosexual Americans. Lesbians also reported higher use of cigarette and marijuana use. Back in the day, and this still happens in med school in a lot of ways, but the thinking was that maybe lesbians or gay Americans or African Americans experience higher rates of like X, Y, or Z disease because of some genetic predisposition. What we're seeing now is that there are things like epigenetics, so somebody experiencing stress that leads to their children already being predisposed to higher rates of substance use. The other thing that we're seeing is that it's not a person's inherent traits in a lot of ways. It's that they're experiencing minority stress in America, which is leading to them using these methods of coping with higher rates of substance use. This also plays out with the prevalence of cocaine, heroin, methamphetamines, ecstasy, and inhalants being higher in sexual minority groups. This doesn't only play out with substance use, but it also plays out with suicide attempts. So this is pretty serious in a lot of ways. Lesbian and gay people, in terms of the prevalence of suicide attempts, were at 24.3% versus 13.1% of heterosexual Americans. In terms of bisexual Americans, it was noted to be 28.3% versus 23.2%. The statistics actually reverse when you look at if people who identified as unsure. So it was 12.4% versus 14.9%. The reason that they think this might actually be happening is because people who identified as unsure may have been able to adapt or camouflage themselves a little bit more inside of society. So they didn't experience as much minority stress and they didn't lead to as much substance use or prevalence of suicide attempts. In terms of the drawbacks of this study, they actually saw that there were probably high dropout rates. So they actually might be underestimating the amount of people who actually might have like had higher rates of suicide attempts or been using substances. The reason that we have to think about this is that a lot of LGBTQ plus Americans, if they are out or if they are outed by other people, will already begin experiencing discrimination. So some of them might not even make it to high school to be able to complete this study. So we might actually be underestimating all of these rates and the prevalence. And since the 2016 election, this has actually only gotten worse. So something for us to all be aware of as clinicians, as well as people who care about other people in general. Since the election, we've actually seen an increase in the rate of not only suicide attempts in some ways, but also the rate of discrimination. So the FBI tracks like different cases that are reported. And so they've noted that every year there's been an increase in the discrimination that in hate crimes that people have been experiencing. That hasn't only played out in terms of coronavirus, but it's also played out in terms of African Americans and all other minoritized groups experiencing higher rates of discrimination. So we kind of have our work cut out for us, and we need to be thinking about how are we contributing to society and how are we using our identities as physicians in order to help stop this from happening, or at least provide a safer space. So, in terms of statistics for Asian American sexual minorities, a lot of the studies I was talking about before noted poor mental health, but they were done predominantly in white LGBTQ plus samples. So, research in Asian American sexual minorities demonstrated that external racial stressors among Asian Americans resulted in greater psychological distress. A study was done at the University of Tennessee and noted that Asian American LGBTQ plus persons experience rejection, prejudice, discrimination from the overall LGBTQ plus community. So one of the things to think about is not only intersectionality, which we'll talk about more later, but just because somebody is part of a community and that community is seen as being overall supportive, it doesn't mean that they can't experience discrimination inside of that community itself. So a lot of LGBTQ plus Americans who are also racial minorities will experience a lot of discrimination from inside of the LGBTQ plus community. And that's something that we've all been needing to talk about more, as well as transgender Americans also experience discrimination inside of the LGBTQ plus community. So always taking a step back to think about the individual and their experience, and also recognizing that just because you fit in a group in some ways doesn't mean you actually are safe in that group. They also noted in the study increased internalized heterosexism, which is also known as internalized homophobia, because of violating traditional Asian values such as harmony and complementarity. And among 314 LGBTQ plus people of color who were studied at the time, 58 of whom were Asian American, they saw higher rates of depression, perceived distress, as well as need for acceptance. There was also internalized homophobia from within versus the general society. So thinking about inside of a culture, does somebody actually push up against the cultural boundaries and norms? And does that actually cause distress for them? So this also happens in African American communities in different ways, where sometimes somebody coming out is seen as not a good thing. And so there used to actually even be a term for this, which was known as being down low. And so somebody who was African American who came out and had to hide who they were in a lot of ways. So thinking about how the general society can impact a person as well as a person's own culture. Along with this come ethnosexual mythologies that they studied. And so an example of this is reducing somebody to their skin color and sexually fetishizing them. The example I always give, which is not always the most fun, but back in medical school in Chicago and then in residency in Boston, I was on Grindr because like I'm gay and like what else do you do? And on those dating apps, sometimes I would get messages like, I love your black skin, or your black skin is so beautiful, without ever actually getting to know me. So reducing me to my skin color. There were also times that people would fetishize me and say, like, oh, I love that big black dick, or like, show me that big black dick. And so, not appropriate messages, and also things that reduce me to my skin color without actually recognizing me as a person. So, this is something that a lot of people have to deal with on these kind of apps and also the general society. Along with this comes competing identities and then also resilience. So they also looked at how Just because somebody is a sexual minority and a racial minority, these things can actually be protective in some ways and useful for them. So, along with minority stress comes intersectionality. So, it's the interconnected nature of social categorizations such as race, class, and gender, which create overlapping and interdependent systems of discrimination or disadvantage, can also create systems of advantage as well. The example I give is that because I'm African American in America, I actually get pretty scared around police people. And we know that there have been a lot of problems recently. So what I do when I walk by somebody who's a policeman is I use my more stereotypically gay things where I will walk in a different way and I also will tilt my voice and inflect it up so I seem like less of a threat. So thinking about how intersectionality can be also protective too. Along with this comes the intersectionality paradox. An example of this is African American women with higher education levels actually had lower rates of depression sometimes than white women who had the same educational levels. They think that part of this might be due to actual socioeconomic standing and also being in a community that was more educated overall and that was protective for them. Along with this comes the multiple jeopardy perspective, which is known as the multiple disadvantages approach. It's also known as the multiple hierarchy stratification. An example of this is an Asian American bisexual female in America would be assigned 3 hits for low status. And the reverse would be a white heterosexual male would be assumed to be the jackpot in America with having 3 high status traits. But we always need to take a step back and look at the person's identity and experience. So I sit before you as African American and gay, and that would be seen as 2 low status traits in America. However, I am socioeconomically advantaged and educationally advantaged. So those things sometimes weigh out. And so we need to always take a step back to look at how is somebody's identity formed, as well as how has that been protective for them. And we also need to recognize that just because somebody looks a certain way or identifies a certain way, we need to always think about their actual lived experience and their story as well. So, what's missing from all of this? After an extensive search on PubMed, on Google, and also we looked on Wikipedia because, like, I'm going to say it, everybody does it. Like, they say not to in med school, but we all do it. We also looked on Plus One as well as ResearchGate. So what's missing is LGBTQ plus research often lumps categories, like all categories together. So it's seen usually under the umbrella of LGBTQ plus. It doesn't break it down into like African American male who is also bisexual. It doesn't break it down into Asian American female who is also transgender. So always needing to take a step back and think about, are we actually breaking these into categories that are appropriate, or are we trying to lump things together to like give data to people? There's also a dearth of research on intersectionality. That's changing as time goes on, and as we see the importance of talking about intersectionality. Also, women are not seen as minoritized when using this model, but if you take a step back, it does apply to women as well. If you think about women inside of medicine, they are underrepresented, especially when you look at the upper echelons of like different professorships, deanships, those kind of categories. They are not promoted as much, and they also have pay discrepancies as well. So this model does fit them in many ways. We also need to look at further racial minority groups. So if you noted when I looked at showed you all the chart and when I've been talking about things, I say like Asian American or I say like Hispanic American. There are a lot of subcategories beneath that that we need to be researching. And so we need to think about that as well. The other thing is that elderly populations also fit into this model in a lot of ways. One of the things that I've researched and also have read about is that a lot of elderly LGBTQ plus like people, when they go to like nursing homes or skilled nursing facilities, even if they were out before going to the facility, they go back in the closet because they feel unsafe. So thinking about how this minority stress model in theory actually fits elderly populations as well. So how does that play out regarding patients? So a couple definitions first. The first is microaggressions, which are broadly defined as behaviors that ambiguously disempower racial minorities. Underneath that, there are actually 3 categories. The first is microassaults, so explicit acts of racism or saying someone is of lesser worth. The next is micro insults, saying you didn't earn your position. The example that I give is when I first started medical school, I was told that, or I won class president, and then I was told immediately after by a classmate that I had won class president because I was Black and gay. And then I had to say to them and had to remember to myself that I won class president because I had gotten to know a lot of people. And I also had been the only person to do a PowerPoint presentation and give a full speech. Along with this also comes microinvalidation, saying we are all the same. We are not all the same. We are born into a society that is racist in a lot of ways, and we are born into different socioeconomic standing. We are not all the same, no matter like if we think we are. So taking a step to recognize that we are not all the same and how do we respect that difference. Along with this comes healthcare microaggressions, which originate from aversive racism, saying we aren't prejudiced, we don't have racist tendencies. Again, that is false. We are born into America, which is built upon like socioeconomic standing as well as a lot of racial biases. And so we all are born into that system and like are imbued with those like racist tendencies as well. It's much more about recognizing that we have those implicit biases and then taking a step back and thinking to ourselves, yes, we have these biases. How do we work against them? And how do we make sure they don't impact patient care and how they don't impact our interactions with others and that we can converse about them in a more nuanced way than we do currently? Along with this comes institutional betrayal. So it's like my favorite term, but it's like kind of a bad thing. So when somebody who is discriminated against comes to a supervisor and says, "Oh, I like was experiencing or I experienced discrimination. This is what happened." How that supervisor or institution responds will actually normalize or actually help that person. If the institution does not respond appropriately, it normalizes that behavior and also will then make that person feel institutional betrayal. And it will normalize it in the way that it will show a lot of other people who hear about the situation that it is okay to be discriminatory towards this person. So, how do institutions themselves actually normalize such behaviors? The way I also think about this is it's happening in America in a like grander scale. So transgender Americans are suffering from a lot of anti-trans discrimination as well as bills that are going through right now. And people who are supposed to be protecting them, such as senators as well as presidents in the past, are not doing so. And so that normalizes hatred against these minoritized groups. In 2007, Constantine looked at the impact of racial microaggressions on mental health treatment of African Americans. What they noted was a lot of minimization or saying, like, what you experience is not that bad. And also was over identification of saying, like, I understand what you're going through. The thing is, we do not understand what any other individual is going through. And so we can empathize with them, but we don't understand. So we always need to think about our language of and not over identify with people. In 2017, Fitzgerald looked at vignettes to examine the influence of patient characteristics on attitudes, diagnoses, and treatment decisions. Nearly all, so 35 out of the 42 articles, found evidence of implicit bias. This was bias around race, age, socioeconomic standing, mental illness, weight, having AIDS, TBI or traumatic brain injury or brain injured patients, intravenous drug users or people with substance use disorders, disability, social circumstance, and gender. So basically everything. We have implicit biases around all of that. They were actually the same levels of implicit bias as the wider population. So the way I think about it or how I try to frame it is the hospital system is a microcosm of the macrocosm that is America. If you took America and shrunk it down to the size of a hospital, you'd be experiencing and seeing the same rates of discrimination. So sometimes in the hospital system, it feels like very pressurized in a lot of ways. And that's because you're experiencing the same rates of discrimination. When physicians were less certain of coronary artery disease for middle-aged women, they were more likely to give mental health diagnoses for women compared to men. And then intersectionality can play a large role in protection versus being a single minority status as well. So always thinking about how intersectionality can be protective for people too. This also plays out regarding residents, and this also maps to medical students as well. Lisi in 2016 looked at bullying, which were repeated acts or practices directed at one or more workers, unwanted by the victim, done deliberately or unconsciously, but clearly cause offense, humiliation, and distress, and may interfere with job performance and or cause unpleasant working environments. Examples of this included unjustified criticism, humiliation in front of colleagues, intimidatory use of discipline/competence procedures, undermining personal integrity, and shifting goalposts. So shifting goalposts, I always explain. So when somebody comes into a rotation, they are told that they need X, Y, and Z to get an A or honors. They do X, Y, and Z. Then their attending will say to them, you also need to do A, B, and C. They do A, B, and C. And then the attending will say, you need to also do D, E, and F. So they're shifting the goal line so that person will never achieve that honors. And this plays out a lot with residents, but it also plays out especially for minoritized residents as well. 69.8% of residents in the US have experienced workplace abuse. The most common form of abuse was verbal in nature. The types of resident mistreatment and themes that they saw were hierarchy. So that's why I always try to say, like, call me Chase, because I'm trying to flatten the hierarchy as much as possible, as well as silence, incognizance, fear. 79% of residents reported that they were afraid to report because of the experiencing backlash, or had they had heard about backlash from other people. There was also a lot of acceptance and denial seen. So saying like, what happened to me wasn't that big of a deal, or what happened to me wasn't real, like it didn't happen. There's also the legacy of abuse. So they've done studies, and if a medical student or resident experiences workplace abuse and then they become an attending, they are more likely to go on to abuse medical students and residents after. So how do we break that cycle? And that's what we've been doing a lot on Twitter, is trying to stop that kind of abuse and set limits. And then hopefully the things that we do on Twitter of setting those examples will play out in the hospitals for people too. Lisi also looked at the sequelae of resident mistreatment. This plays out on the individual and systemic levels. There's a cost to the system with higher medical errors, harm of patients, and dissolution of care. 67% of residents who witnessed disruptive behavior or workplace abuse felt it contributed to adverse events for patients. There's also a cost to the individual. There's higher burnout rates, thoughts of desertion or leaving their programs, depression, stress. A lot of studies now are showing that residents and also medical students who experience workplace abuse will actually have symptoms of PTSD. That includes nightmares, hyper-awareness, hypervigilance, and things of that nature. They also have higher rates of substance use and higher rates of suicidal ideation. And this is actually compared to age matched peers. So when an individual comes into medical school, they actually have the same rates of depression as their age matched peers. That skyrockets pretty soon as when they enter the system. And so thinking about how medical school and medical culture in and of itself is causing these higher rates of stress and substance use and suicidal ideation. 20% of residents said they would not pursue medicine again, and several would advise others not to pursue as well. So all of that's pretty shocking in some ways, and it's a lot. So how do we help and how do we grow? The first thing we can do is we can ask. When Mark and I first did this presentation, I used to just say like, we ask questions. And then I had to take a step back it was about a year later when I was giving this presentation to other people. And the reason I put a caveat to this now is that asking people about their experiences about discrimination can be extremely invasive. I didn't realize at the time that it felt invasive to myself. I was always like, oh, I need to answer this question because it'll help fix this person. It'll help fix racism at this university. It doesn't. Um, it also put the onus on me to explain racism to somebody instead of having them do the work to like figure that out themselves, because there's enough literature out there for them to figure it out if they want to. So what I do now is I say that we can ask, but we always need to give a person an out so they don't have to discuss this if they don't want to. The way I do this with patients is I have questions about minority stress woven into my first intake interview with them. And then if they say that they are a minoritized person in America, I will then go down like my little question list, and I will start saying, I will broach this by saying, so I said that you identify as somebody who's minoritized in America, and I know that that can come with a lot of racial stressors as well as discrimination. I am here to talk about those things if you want to discuss them more, but I understand that not everybody wants to or has the energy to do so. So if you don't want to discuss that right now, that is completely fine. I will be here for when you do want to discuss it. That gives them that out, but also shows them that the door is open for them to discuss those things if they want to. Along with that, we need to educate ourselves. A lot of transgender patients, I believe it was 25 to 30%, had to explain what being transgender meant to their providers. So we need to come to the table with a bit more knowledge. If we're able to learn things about like hyponatremia over and over again, we can learn things about how a patient's identity impacts their lives. We also need to protect minoritized people, and we need to become actual allies. There's this danger of false allies where people say that they support diversity and they are anti-racist, but what actual policies and work are they doing to actually prove that they are true allies? We need to come at this from humility, from seeking to understand and truly converse. One of the things that can happen in medicine is we are taught that we can never be wrong and we always have to be right. We get things wrong all the time. We will get things wrong around racism and around discrimination. How do we take a step back and apologize when we do get those things wrong and say, here are the things I understand, but I don't know everything about your life. I am here to help you and I'm here to learn and also become better. We also need to believe minoritized people when they bring these issues forward and we ask, but with that caveat that I mentioned earlier. How do we heal? So Lisi actually did like went through basically different things that could help heal residents as well as medical students and decrease the amount of bullying. These things that they looked at actually map to how to help minoritized populations in a lot of ways. So education and awareness in and of itself led to decreased bullying. So just coming to this talk, it makes you a little bit more aware. It helps you with the terms and verbiage to not only help patients, but also think about like when you see something, you will now know like, oh, this is like a microaggression. This is a micro insult. This is this, that, or the other. And then you can start thinking about solutions. Team-based care at all levels helped to reduce the hierarchy. Good leadership led to prevention and protection and defined culture. Interphysician support led to more mentoring and fostered a better community. There was also a need for confidential mental health services. So when medical students come into medicine, they should actually be in an opt-out system where they are linked with a therapist or psychiatrist and they can say like, oh, I don't need that at this time, but we need to have that in place for them so they aren't scrambling when they do experience mental health outcomes. We also need to develop a curriculum that tackles the hidden curriculum because half the game in medical school is learning medical facts. The other half is very much learning to navigate the social system that exists in every medical school. We also need to standardize feedback and reporting methods and have a safe mechanism for reporting that doesn't lead to backlash against people who report. And in the worst case scenario, we need to also build exit strategies. So some universities and places are not ready to have minoritized people at their university. They do not adequately support them. So how do we find a place that it does support them without any repercussions? We need to also recognize, name, and understand these attitudes and actions, and also identify our own implicit biases. We need to do diversity training, not only about diversity now, but also diversity that has happened in the past. Medical schools need to be better about how we teach about racism within the medical system itself. A lot of med schools will not touch this topic because they don't want to be seen as, oh, we did things wrong. Every institution, every place, America has done a lot of things that have been wrong. We need to embrace that that has happened in order to move forward and not keep doing the same cycle that we do of making the same mistakes. We also need continued research and also address patient social risk factors and needs and diversify the healthcare workforce. This also comes with a caveat that I didn't used to have. One of the things that happened in residency when we would do interviews and also thinking about recruitment, people would say, let's bring in more diverse residents. And we actually had to stop them and say, just bringing in diverse residents doesn't help because they don't have the power and they don't have the backing that they need to affect the changes that they should, as well as this is not their job. No minoritized resident is signing up to go to a university to fix their university. So what you need to do instead is bring in diverse workforce that actually is able to enact different changes. So you need to bring in more diverse deans, you need to bring in more diverse professors and things like that. So when you do have minoritized people who come through, they actually have outlets and people to talk to who understand what they're going through. Because otherwise what you're doing is building a pipeline from coming into the university to going straight out somewhere else after. This is also for further reading, and then I used to put this, but, like, I barely have time to read anything that I even, like, wanna do, so, like, I understand you guys are, like, in med school and, like, doing work and stuff, and, like, dude, I have time to read this probably. But it's about reducing racial inequities in health, so taking what we already know and building upon that. So I can send that if you guys want, but don't worry about it. So rising from the ashes. So this is going into what does all of this have to do with how I formed my identity and also how I leveraged social media in order to advocate for others. So we're going to go into that a little bit. And this is the part you guys feel free to like ask all the questions because like this is a new part that I've added. So once upon a time, there was a black gay unicorn phoenix little resident somewhere in Boston. That person was me. I'm going to go back a little bit. And I had left med school. And during med school, or well, actually, I'm going to go back a little bit farther. Before I started med school from seventh grade through college, I'd actually been pretty depressed with suicidal thoughts and suicidal ideation, as well as two suicide attempts at the time. Yeah. And What happened though when I got to MIT was it was a better environment. It was very safe for me. People were like, we just want to be good people. And like we've all been bullied too. So like let's be nice to each other. So it was a very freeing environment and I was safe. My depression before I started graduate school at MIT went away. And I had never taken meds. I'd never gone to therapy. I was very much like, ooh, I'm cured. Like, and then I also, when I left MIT, I was like, oh, the world is right for a Black gay person because, like, I'm doing great here. And I went to med school. And I was like, oh my God, America's racist as shit. I don't know if I'm allowed to swear on here. I already did it, whatever. But then I became pretty depressed actually in med school. And this was all while being class president and hearing things about like race and diversity and racism that I was shocked that people would ever say. And I was like, these are my classmates who will be taking care of patients later. These are faculty members who will be taking care of patients later. I was very fortunate at the time that I had a vice dean that I reached out to in my second year, and she wrote back to me and said, you are an asset to this school, and I will do whatever I need to help you survive and thrive here. She and I made a lot of changes to Northwestern, and she still is there and somebody that I keep in touch with. Once I started writing the articles about a year ago, she reached out and was just like, we're connected on Twitter, and she was just like, I read all your articles and thank you so much for being so open. So, like, that was an actual ally. I left medical school not depressed because I had started medications for the first time, and I was also in therapy for the first time as well. And I was like, okay, I just have to get back to Boston with my friends, and everything will be fine. Like, Boston is a great city. I've lived there. It's great. It's going home. I will be safe. Roll to about 6 months into residency, and I had been told that I was unprofessional. I had been told that I didn't know what I was talking about with different things. I was also stopped during rounds and interrupted while my white colleagues were able to talk about whatever they wanted. I was told that I was unprofessional for not wearing a tie. That became a huge debacle where there were several meetings of faculty members about my not wearing a tie. There were also people who mixed me up with the only other African American person in our residency who was bald and like did not have purple hair at the time, and was from Oxford. So just a lot of different things were going on then. I was lucky this time around that I had my friends from MIT who were still there, and were very supportive, but I became depressed again, and pretty actively suicidal most of the time. So I felt very stuck. I didn't know what to do. I was making changes, and about a year and a half into residency, one of the program directors who had said I was unprofessional was crying when she told me that she finally understood what I had been talking about and she needed to apologize for how she had treated me. She became an ally, but it was a lot of work that I had to do to get her there, as well as other people. And then she eventually, about a year later, so this was going into my third year, she left for a different university. And at the time, I was planning to leave as well, but I felt like pretty stuck and I didn't have my voice anymore. I'm known for being very vocal, but I'm actually pretty shy, and it's really hard for me to speak up. So I felt like I didn't have a voice. And my friend Jack Turbin, who I think a lot of you might follow on Twitter too, but he was one of my co residents, he had been telling me for about 3 years to start a Twitter account. And I was like, why? It seems like more work. And he was just like, well, because you can pop off and talk about shit. And I was like, have you seen me at this university? I can't talk about anything like openly without getting in trouble. And he's like, well, what if we did it under like a pseudonym? And I was like, oh my God, yes. Like, we're going to House of God this shit. And so what we did together one day was we came up with Casey Artem. So Casey is from Camp Kesem reversed. So I took the letters and reversed them. And so Camp Kesem is a camp for kids whose parents have cancer that I like did charity work for back at MIT. And then Artem is dream. So it is like differently spelled, or I moved the letters around. And Dream came from a lot of my friends at MIT. It's my nickname with them, because they said that I always inspire people to dream like of a better future. So then I like was like, okay, so how do we do this? So came up with like Sailor Moon is my background and everything because like Sailor Moon was important to me. And then also we used the Salem the cat, as like my little avatar at the time because Salem the cat like represents me. Where like I'm a good person underneath, but like world domination, like if it happened, that'd be fine. Like if gays took over the world, I think it'd be a better place. Um, and then started using GIFs and started talking about like medicine in general. And it was pretty scary when I first started doing it because I was worried that my university would figure out who I was because I have a certain way of talking and a certain way of writing that like is kind of stylistic. So I even had to change how I wrote things. And then along the way, I had seen somebody else write on their Twitter, like "Good evening to everybody. Who do we hate today?" And I was like, okay, I like think this is funny, but I want to change this around in a certain way. So what I started doing was "Good morning to everybody except," and so then I would start saying like "Good morning to everybody except like police people who shoot black people. Good morning to everybody except universities that talk about supporting minoritized people but then discriminate against them behind closed doors." So that's how that all started actually. And I think it was one of the most freeing things that happened in residency. It gave me my voice back in a lot of ways, and it gave me a way to speak in a way that I hadn't been able to for 7 years. So then things started building, and I then actually wrote an article underneath the guise of like Casey Arnhem. It's called a physician's experience of bigotry in medicine, and then went through all of residency and was still under the pseudonym because I was very scared about what would happen. Then I left and went to UCSF, and I was walking along the street one day, and I had noted by that point that there were so many other physicians who felt the same way. There were other medical students who felt the same way. There were other people who had gone through tons of discrimination and felt horrible about who they like were told that they were, even though they were good people. Um, Everybody in medicine, I think, overall is a good person. And minoritized people experience a lot of discrimination that they don't deserve and didn't ask for. So I was still under Casey Artem at the time, and then I was like, maybe it's time to be myself. Part of that safety came from a lot of people at UCSF had also been talking openly about like their own mental health. There's this guy named Justin Bullock. He actually went to MIT and we were friends and in the same fraternity. And he was speaking openly about his mental health too. And then I was like, maybe it's time to be myself. And so then I changed my name to my original name and like had a whole GIF like thread of like it was RuPaul and all the like RuPaul best reveal things. And I was like, "Hi, I'm Chase Anderson. Like I'm the same person that you know, and I'm still here to take on bigotry and I'm here to help." Um, so I think I use that example to show that a lot of minoritized people aren't allowed to speak. It's hard for them to speak up at their universities. They experience backlash, and this was showing how social media gave me a platform. I had to always build platforms by finding the right people who were allies at universities. And I realized that, and Jack and I talked about this, that I was spending so much time fixing universities that I could have been using helping the people who needed it most, which were like other LGBTQ and like other underrepresented minority people. And so that's why social media was important because it gave me a way to access and reach the people who needed to hear that they weren't alone too. Okay, I'm gonna keep going because these are new slides. And then once I came out, we actually started doing more like gathering things. There was already pretty like a budding LGBTQ plus community of physicians that actually got bigger and bigger. And now we do like the what do you call them? We do like roll calls and things like that. And so I've actually noted and gotten messages from people who say like seeing the roll calls of like physicians who are in medicine have like helped me be out in like my school now. And so people will change their bio so they have like the little pride flag and stuff. And it just built a community in a lot of ways. And there's a Black physicians group, and it's called Wakanda Forever. And so we like have our own little chat thing where we like talk about things in America. And so a lot of physicians who are minoritized are siloed in a lot of ways at their university, or they feel like they're alone. And social media is a way to connect with people and figure out that you're not alone. So that's like my story overall. I'm here for any questions about that and like other things about social media, but that's, I think, showing how important it's been in my life. It gave me a way to speak and it got me to where I am now, and I wouldn't trade that for anything. So. And then with special thanks to Mark, and then also Kelly, and then you see Irvine, and then my other mentors, past and present. Okay, yeah, that was it.
Thanks for the shout out, Chase.
Of course.
So I hope you understand that social media is not just, it can just be a place for like a fun outlet and a release, but as people who have been put on this pedestal that is medicine and society, oftentimes we have to navigate how our identity is expressed, viewed, utilized on social media platforms. And I think it's good for us to have a foundational understanding of the stress that can be associated with that vulnerability on social media platforms,
Mm.
but how it can also be a refuge. And so I hope that was the message that people could gather. I think it fits really nicely in the theme that we had today around stress and trauma. We heard today about trauma informed care. We heard today about the racist histories of the medical profession. And so I hope this all makes sense today for folks. We wanted to dedicate some really specific time for people to just ask questions of Chase around his experience navigating social media, his experience trying to figure out his own identity, because I think we've all had our individual struggles. Medicine forces you to figure out who you want to be really fast. It forces you to figure out what you want to do for the rest of your life in a matter of 3 years at the age of 22, right? So I think it's necessary for us to sit and pause about how and think about how important identity really is. So the chat box is open, or if people want to unmute themselves and just ask, feel free to do so. So a first question coming from Julie. Do you know how many medical schools actually implement an opt-out policy for psych services? It seems like such a great idea.
Yeah. So there's an article that I shared from a friend, and it was talking about just one school. So I've only heard of that one, to be honest. Like other schools, when we've asked, like even UCSF doesn't have it. What they'll do is they give you resources at the beginning. So this is what a lot of schools do. They'll be like, here are these resources, here are these like psychiatric care places that you can like reach out to. Um, in residency, they had that, and they were like, here are these physicians that you can reach out to for psychiatry help. We called that list, and like half of them were dead. Like they'd actually died, like because they were old. So it's not as up to date as you would think. Um, I've only heard of one school so far that has done that. And it's something that I think a lot of us are trying to push for now, especially with what we're seeing with how the medical field is affecting not only minoritized people, but just med school is stressful. It's like a lot. And so we need that system in place, because what happens is a lot of people, when they experience like a mental health issue, is then they're trying to scramble, or they try to hide it because they feel embarrassed, or the system is not like built for them to be open about themselves. And if they're trying to find mental health access, sometimes it can take 6 months to a year. I actually put a patient on a wait list for getting a therapist, and it will like they said the wait list is a year long. So imagine like a physician having to go through that, and even knowing the system, like it still takes just as long sometimes. So schools need to be implementing this more. And it's something that I think a lot of people are pushing for, of like you come in and you're matched with a therapist, or you match with a psychiatrist, or you match with a like psychiatric group. And so if you have an issue, then you can go to them, but you don't have to if you don't need to. But yeah, so you're right. It's great, but we don't have any enough places yet.
And that's why we're here, right? To source solutions to some of these issues around stress.
Yeah. Yeah.
A question I certainly like, personally have um, is how you find the energy to be such a public figure. Because of your vulnerability, people are drawn to you because it's such a unique place to be, right? I imagine that your DMs are ridiculous. I imagine that your inbox is ridiculous because you've made yourself available in a way that a lot of people haven't. I'm curious about how you manage that burden, the stress with finally being free and authentic.
Yes, that is an excellent question, and one I've struggled with in a lot of ways. It was something I struggled with too when I first started being so open, because taking care of your class as class president is different than getting messaged by some rando person on Twitter being like, here's my life story. Can you help me? And that was something I like had to navigate at the beginning of when I started being open. People would reach out and say like, sometimes they didn't even say hi, and then they would just dump all this info. And I was like, okay, this is a sign that they're in distress. And like, how do I calm them down a little bit and like set some limits? That's why psychiatry, like, okay, psychiatry is the best field. I'm just gonna say that. I love all the other ones, but like, I love psychiatry. Psychiatry is a lot about setting limits. And I had to employ that on Twitter. I think some of you know, I like on Twitter, I'm kind of am Twitter's therapist in some way, or like Twitter's therapist. And I'm like, let's calm this down. Let's do this. That's a lot of psychiatry stuff that you learn. In terms of my DMs, you're right. They're flooded a lot of the time. And it's sometimes a lot of requests and other things. And what I've had to do is I have my standard message of like, hey, I'm dealing with a lot right now. And I'm pretty open with people, even in DMs. I say, like, I'm dealing with a lot of things and I have a lot of projects. I'm taking care of patients. I will get to this when I can. Please know that, like, you are one of many people that I'm working with right now or like speaking to. Um, if it's an inappropriate message, then I actually will just set limits very quickly and say, like, this is not an appropriate message to be sending. It's something that I do in real life too. Like when somebody is racist or something like that, I'm like, this is not appropriate right now. And I have my like Rolodex of responses in person too. I think also I find the energy because I'm trying to create with other people a positive symbiotic loop. I've noted that like LGBTQ plus med Twitter is like a huge thing, and it's just a nice group of gay people being like, let's just be nice to each other. So that's where that energy comes from. Is like I've seen the power of like being open about yourself. And so that's why I keep doing like what I do. That's why I keep being open with people, and I will keep doing that no matter like how flooded my DMs are. I will always be open because I know that being open helps other people. The way that I think about it is J.K. Rowling, even though she's like a huge transphobe, did a really like nice quote with Neville Longbottom in book 7. And it's when Harry comes back to Hogwarts and Neville's like, I noticed that when you stood up to people and stood up for people, other people felt okay to stand up for themselves and for other people too. So that's where I get that energy from is like, I like, I cannot tell you the amount of joy it brings me when somebody messages me and they're like, I now feel okay coming out at my university. Or like look at my banner and I look and like they've changed it so they have like the trans flag or like the pride flag or like a Black Lives Matter thing or like a black fist. Cause like I used to be pretty scared about like being part of Black Lives Matter kind of things because I was like, oh my God, like it's not seen as great in society. Now I'm like all the time. And like, so it helps you seeing other people embrace themselves has been the greatest gift. And I will always keep doing that because I think, like, look at all of us sitting here. We're talking about the things that matter. Like, you will learn the medical facts, you will learn, like, the random, like, pseudo, para, hypo, whatever. Like, you'll get there. But what kind of people will we be when we get there? And I've seen that leveraging our social media platform and being open myself has maybe helped people start that journey a little bit faster than I was able to for myself as well. So I hope that answers that question. I can dive more if you want me to.
It does. It's certainly something that I'm struggling with, so it helps. It
Okay.
does. So the chat box is open for people to ask any questions, or you're free to unmute yourselves if you have any directly. But generally, we want to thank you for being here with us today. We hope you can continue to be a part of this elective space because I think it was a really nice bow on all of our themes today around trauma and stress and offering solutions for managing trauma and stress. So thank you for being with us. We appreciate you.
You guys are all amazing. This was really wonderful. And I'm here for any questions that you guys have. Like nothing is off the table. So